Hello. So today we're gonna be attempting some past medicine questions. Let's see if we can do 100 in one go. A 50-year-old man is admitted to resus with a suspected anterior myocardial infarction, and ECG on arrival confirms the diagnosis of thrombolysis is the diagnosis and suspected anterior myocardial infarction. ECG on arrival confirms the diagnosis. So it does have a myocardial infarction, and a thrombolysis is prepared. The patient is stable and his pain is well controlled with intravenous morphine. Clinical examination shows a blood pressure of 140/84, pulse of 90, and oxygen saturation of 97. What is the most appropriate management with regards to oxygen therapy? 97% in room air, you don't need oxygen therapy. Next question. A mother brings her 4-year-old daughter into surgery and she thinks she may have NITS. Which one of the following statements regarding head lice is not correct? So NITS is head lice, is it? Malathion is an option for first-line treatment. I think malathion is second line after permethrin. I'm not sure. That's the case for scabies. For head lice, I'm not so sure. Fine-tooth combing of wet or dry hair is the standard way of diagnosing head lice. Is it? Which one is not correct? Children should be excluded from school until treatment has been started. Caused by pediculus capitis, wet combing alone is a suitable first-line treatment. Head lice. Are you sure wet combing alone is suitable first line? Oh, it is. So the one that's not correct is children should be excluded from school until treatment has been started. School exclusion is not advised for children with head lice. Head lice, also known as pediculosis capitis or NITS, is a common condition in children caused by a parasitic insect, Pediculus capitis, which lives on and among the hair of scalp of humans. Cool. Let's look at the 9CKS. Well, first we have to VPN to UK. Let's set up VPN. Oops. I turn off setup VPN. Never mind. Let's connect the... Can I select UK for this? No, I can't. So manage extensions, go to setup VPN. Let's set up VPN. Need to enable this. Okay. Now I have it. I'm gonna port to the UK. Once I'm connected, go to my CKS. Head lice. Summary. Head lice are parasitic insects that infest the hairs of human head and feed on blood from the scalp. Head lice infestation is known as pediculosis capitis. The severity of infestation varies from a few lice, less than 10, to more than 1,000 in severe cases, but typical infestation might have about 30 lice per head. If left untreated, head lice infestation may persist for long periods. Detection combing is the best way to confirm the presence of lice. This is the systematic combing of wet or dry hair using a fine tooth 0.2 to 0.3 mm apart head lice detection comb. A diagnosis of active head lice infestation should only be made if a live head louse is found. The itching scalp is not sufficient to diagnose active infestation. The presence of louse eggs alone, whether hatched, NITS, or unhatched, is not proof of active infestation. A person should only be treated if a live head louse is found. All affected household members should also be treated on the same day. Depending on the preference of the person and or their parents or carers, their treatment history, the presence of any contraindications and course of treatment, head lice can be treated with one of the following: a physical insecticide such as dimethicone 4% lotion, a traditional insecticide such as malathion 0.5% aqueous liquid, wet combing with a fine tooth head louse comb such as bug buster comb. So this is one of the options. No treatment can guarantee success, but a treatment has the best chance of success if it's performed correctly and if all affected household members are treated on the same day. Detection combing should be done after all treatments to confirm the success of the treatment. If treatment is unsuccessful, there is life loss is found after treatment, it should be confirmed that the treatment was used correctly. Household members, close families, and friends and close friends, both adults and children, should be assessed to identify possible sources of reinfestation. The same treatment should be repeated or a different treatment tried. If malathion was used, the possibility of resistance should be considered. People should be advised that children who are being treated for head lice can still attend school. There is no evidence that head lice have a preference for either clean or dirty hair. There is no need to treat, wash at high temperature, or fumigate clothing or bedding that has been in contact with lice, as the lifespan of head louse is very short, 1 to 2 days, once it's detached from the human head. Essential oil-based treatments and herbal treatments are not recommended due to lack of good quality evidence on their safety and efficacy. It is not possible to prevent head lice infestation. Children of primary school age should be examined regularly at home using a detection comb to identify infestations early. Cool. So malathion is an option for first line. Wet combing suitable first line as well. Caused by pediculus capitis, correct. Fine tooth combing or wet dry hair, standard way of diagnosing head lice, correct. And they shouldn't be excluded from school. Okay. Let's connect. Next question. A 37-year-old woman presents for a review. She is 26 weeks pregnant and has no problems with her pregnancy to date. Blood pressure is 144/92, that's slightly high. Arise from her booking reading of 110/80. Does she have preeclampsia? A urine dipstick reveals the following: protein negative, leukocytes negative, blood negative. So it doesn't have preeclampsia, but it has pregnancy-induced hypertension. What is the most appropriate description of her condition? Not preeclampsia, gestational hypertension, or pregnancy-induced hypertension, which is the same thing. Normal physiological change in blood pressure? No. Pre-existing hypertension? No. Gestational hypertension. Next question. A mother brings her 6-year-old son to the GP. The mother says that she has found it extremely difficult to control her son's behavior. She explains stories of her son rarely listening to her, constant bickering, and even fighting. A referral is made to the pediatrician, where after an assessment he may be started on methylphenidate. Which of the following is a side effect of this drug? So assuming this is a treatment for ADHD, I assume. Methylphenidate, what does it do? Not sure what it does. Sounds like weight gain might be a side effect. Nope, the answer is stunted growth. A side effect of methylphenidate is stunted growth. Yes, so this is a treatment for ADHD. Restricted growth is a potential side effect for a small minority of patients on methylphenidate. The mechanism is thought to be through a decrease in appetite. Patients under the age of 10 should have their weight and height plotted at regular intervals. Other side effects of this drug include insomnia, weight loss, anxiety, nausea, and pain. Here's some notes about ADHD. Let's look at what Osmosis has to say about ADHD.
What most people know or think they know about attention deficit disorder, or ADD, is that it's used to describe someone who can't stay focused, and when they really can't focus, they have attention deficit hyperactivity disorder, or ADHD. This continuum from one to the next isn't quite how it works, though. ADD and ADHD are actually synonymous, as in they're the same. ADD is an outdated term used prior to 1987, after which it evolved into ADHD to encompass more of the symptoms that people with ADHD often experience, which, in addition to being inattentive, includes both hyperactivity and impulsiveness. So somebody might be diagnosed with ADHD because they have symptoms related to not being able to pay attention, but they might also be diagnosed with ADHD if they have symptoms related to being overly active and impulsive. They might also have ADHD if they have symptoms of both. According to the Diagnostic and Statistical Manual for Mental Disorders, the 5th edition, the most recent update being in 2013, ADHD is split into 3 subtypes: inattentive, hyperactive, impulsive, or both. Inattentive and hyperactive impulsive have a set of 9 symptoms each. For example, someone with the inattentive subtype might make careless mistakes, or not listen, or be easily distracted. And someone with a hyperactivity and impulsive subtype might fidget, or squirm around, or get up from their chair often. Now, you might be thinking that everyone fidgets now and then, right? Well, a diagnosis is given when someone has 6 of the 9 symptoms for either subtype for at least 6 months. Most commonly, though, children have symptoms of both subtypes, and therefore have a combined subtype. Since ADHD is considered a neurodevelopmental disorder, the symptoms also have to have started between age 6 and 12, and the behavior can't be appropriate for their age. Alright, but what causes someone to be hyperactive, or impulsive, or inattentive? Well, as you might guess, it's pretty complicated, and we don't really know. Probably a lot of different factors, and ultimately they all fall into some combination of environmental and genetic factors. One interesting clue to a genetic component of ADHD is looking at families. For example, a child with a sibling that's been diagnosed with ADHD is more likely to develop it themselves. Furthermore, if those siblings are identical twins, meaning they have the same DNA, their chances of developing ADHD is considerably higher. Having identical DNA doesn't mean that the twin is definitely going to develop ADHD though, which again suggests that both genetic factors and environmental factors play a part. As to a specific gene, it's probably not one single gene that leads to ADHD, but rather multiple genes that determines how severe their symptoms are. These genes likely influence the production or regulation of the brain's neurotransmitters, which are signaling molecules in the brain that are released by one neuron and received by receptors of another neuron. This movement of a neurotransmitter from neuron A to neuron B is basically a message being relayed. It's like the neurons are talking. Dopamine is a specific neurotransmitter that gets released when the brain's involved with behaviors like getting a reward, taking a risk, and being impulsive. Norepinephrine is another neurotransmitter involved in attention and arousal. It's thought that lower amounts of these 2 neurotransmitters floating around contributes to symptoms of ADHD. The reason why these neurotransmitters might be down in the first place is still not well understood, and research remains ongoing. Now, treatment for ADHD can be tricky since symptoms might vary from patient to patient, although it most often involves either behavioral psychotherapy, medication, or both. Behavioral psychotherapy is often targeted at children and focuses on teaching the child better time management and organizational skills. For example, having structured routines that they can follow, and then giving rewards when they stick to those routines. Also, involving both parents and teachers are important, and both behavioral parent training and behavioral classroom management have been shown to be helpful for children with ADHD. For adults, behavioral psychotherapy might focus on ways of decreasing distractions, and also improving organizational skills. If medications are prescribed, typically the first-line options are stimulants. Since it's thought that low levels of neurotransmitters are involved in ADHD, stimulants are used because they tend to increase the number of neurotransmitters, like dopamine, between neurons, therefore reducing symptoms. Common and well-known ADHD medications are molecules that are chemically similar to illicit stimulants like methamphetamine, but there are some key differences to keep in mind here. All of these chemicals help to increase the release of dopamine from neuron A, but the ADHD medications typically cause a slow release of dopamine, whereas illicit stimulants like methamphetamine cause a really fast release of dopamine. In fact, it's this incredible surge of dopamine that disrupts normal communication between neurons and produces euphoria, and is the reason that illicit substances like methamphetamine are highly addictive. In contrast, the slow and controlled release of dopamine caused by ADHD medications is key, and helps a lot of patients improve their focus and their attention. Thanks for watching. You can help support us by donating.
See what's ADHD according to osmosis. ADHD, March 2018 saw a nice issue new guidance about recognizing and managing attention deficit hyperactivity disorder. This condition can inflict significant morbidity on the child's life and thus has consequences into adulthood, making a good diagnosis and treatment vital. DSM-5 defines ADHD as a condition incorporating features relating to inattention and/or hyperactivity or impulsivity that are persistent. Like many pediatric conditions, there has to be an element of developmental delay. For children up to the age of 16 years, 6 of these features have to be present. In those aged 17 or over, the threshold is 5 features. Table below. Epidemiology: ADHD has a UK prevalence of 2.4%, about twice that of autism, and is more common in boys than girls. Male to female ratio of 4:1. Most children are diagnosed between ages of 3 and 7. There is a possible genetic component. Diagnostic features: they have inattention or hyperactivity. Inattention includes does not follow through on instructions, reluctant to get engaged in mentally intense tasks, easily distracted, find it difficult to sustain tasks, find it difficult to organize tasks and activities, often forgetful in daily activities, often loses things necessary for tasks or activities, often does not seem to listen when spoken to directly. Hyperactivity or impulsivity, unable to play quietly, talks excessively, does not wait for their turn easily, will spontaneously leave their seat when expected to sit, is often on the go, often interruptive or intrusive to others, will answer prematurely before a question has been finished, will run and climb in situations where it's not appropriate. Management. NICE stipulates a holistic approach to treating ADHD that isn't entirely reliant on therapeutics. Following presentation, a 10-week watch and wait period should follow to observe whether symptoms change or resolve. If they persist, then referral to secondary care is required. This is normally to a pediatrician with a specialist interest in behavioral disorders or to the local child and adolescent mental health service, CAMHS. Here, the needs of and wants of the patient as well as how their condition affects their lives should be taken into account to offer a tailored plan of action. Drug therapy should be seen as a last resort and is only available to those aged 5 years or more. Patients with mild or moderate symptoms can usually benefit from their parents attending education and training programs. For those who fail to respond or whose symptoms are severe, pharmacotherapy can be considered. Methylphenidate is first line in children and should initially be given on a 6-week trial basis. If it is a CNS stimulant which primarily acts on dopamine or norepinephrine reuptake inhibitor. Side effects include abdominal pain, nausea, and dyspepsia. In children, weight and height should be monitored every 6 months. If there is inadequate response, switching to Dexamphetamine should be started in those who benefited from dexamphetamine but cannot tolerate its side effects. In adults, methylphenidate or lisdexamfetamine are first-line options. Switch between these drugs if no benefit is seen after a trial of the other. All these drugs are potentially cardiotoxic. Perform baseline ECG before starting treatment and refer cardiologists if there are any significant or past medical history or family history of any doubt or ambiguity. Like most psychiatric conditions, whether adult or pediatric, a thorough history and clinical examination are key, especially given the overlap of ADHD with many other psychiatric and physical conditions. Let's look at methylphenidate, how it works. Right, it's methylphenidate, right? Okay. Therapeutic indications for ADHD. Pharmacodynamics. Psychostimulant agents used for ADHD and nootropics, centrally acting sympathomimetics. Mechanism of action: methylphenidate is a mild CNS stimulant with more prominent effects on mental than on motor activities. Its mode of action in man is not completely understood, but its effects are thought to be due to an inhibition of dopamine reuptake in the striatum without triggering the release of dopamine. The mechanism by which the methylphenidate exerts its mental and behavioral effects in children is not clearly established, nor is there conclusive evidence showing how these effects relate to the condition of the central nervous system. Methylphenidate is a racemic mixture containing D and L enantiomers, where the D enantiomer is considered as the pharmacologically active enantiomer. Reuptake of dopamine. In the striatum. Okay. It's a side effect of stunted growth from not having enough appetite. Sure. A 50-year-old woman in the general medical ward complains of palpitation. She denies any chest pain or shortness of breath. Her ECG shows supraventricular tachycardia, AVNRT, was diagnosed. Her blood pressure is 135/86. Initial valsalva maneuver fails to restore sinus smooth rhythm. Your consultant asks you to give her adenosine. The only access available is a 20-gauge small cannula in the dorsum of her left hand that is currently being used for infusion. What is the most appropriate way of administering adenosine in this patient? I believe a larger gauge cannula is needed. To phrase it this way, insert a 16-gauge cannula in the right antecubital. IV adenosine needs to be infused via large caliber vein or central route. Adenosine cannot be given orally. Adenosine's half-life is less than 10 seconds, and therefore a central route or large caliber vein is required to administer adenosine effectively. In this case, the cannula in her left arm is unlikely to be large enough for adenosine, while a central route is an appropriate route. It is more practical to insert a peripheral cannula into the antecubital vein for rapid adenosine IV injection. A large bore cannula, preferably 16 gauge, should be used. The smaller the number, the larger the bore. What's Abnrt? Abnrt, preview, huh? Okay. No. Okay, this guy. Goody.
The atria are the heart's upper chambers, and the ventricles are the lower chambers. Reentrant tachycardias are fast heart rates caused by electrical signals that loop back on themselves. Normally, an electrical signal starts at the sinoatrial or SA node in the right atrium. It then propagates out through both atria, including Bachman's bundle in the left atrium, and then contracts both atria. It's then delayed just a little bit as it goes through the atrioventricular or AV node before it passes through the bundle of His and onto the Purkinje fibers of the left and the right ventricles, causing them to contract as well. Usually, the only place where a signal can go from the atria to the ventricles is at the AV node. And once that signal gets to the Purkinje fibers, it stops, and the heart tissue waits for another signal from the SA node. With an atrioventricular reentrant tachycardia, or AVRT, the electrical signal actually uses a separate accessory pathway to get back up from the ventricles to the atria, causing the atria to contract before the SA node sends out another signal. The signal then moves back down the AV node to the ventricles and the Purkinje fibers and contracts the ventricles, as well as goes back up that accessory pathway, and then the cycle repeats, which is why AVRT can result in rates as high as 200 to 300 beats per minute. This type of tachycardia is known as a supraventricular tachycardia because the signal causing the fast heart rate originates above the ventricles. The most common type of AVRT is Wolff-Parkinson-White syndrome, where the accessory pathway is called the bundle of Kent. This type of reentry is known as an anatomical reentrant circuit because the accessory pathway is a fixed anatomically defined pathway. Another type of reentrant circuit, though, is atrioventricular nodal reentrant tachycardia, or AVNRT. AVNRT, just like AVRT, is a type of supraventricular tachycardia, but with AVNRT, it's in or near the AV node, which, just like before, contracts the ventricle and the atria every time it goes around. Specifically, there are two separate electrical pathways that make up this loop, and one of these pathways has heart tissue that has slow electrical conduction, and it's called the alpha pathway, and the other has fast conduction, and it's called the beta pathway. Not only that, though, the alpha pathway has a short refractory period, which is the time it takes to be able to conduct another signal. The beta pathway, on the other hand, has a long refractory period. Once you have all those things, you've got yourself a recipe for AVNRT. So now let's say a signal comes down from the SA node in the right atrium. The signal goes down the fast pathway and reaches the other end before the slow pathway, and then splits to travel down to the ventricles, as well as up the alpha pathway, where it meets the slow signal and they both cancel each other out. At this point, both go into their refractory period. Except the alpha pathway is shorter, right? So it comes out of refractory sooner and it's ready for another signal, while the beta pathway is still in refractory. So if another signal comes by, it'll start down the slow pathway, but since the fast is still in refractory, it'll be blocked. At some point while the signal's going down the alpha side, that beta side will come out of refractory, and then it'll be ready to go. So now as that signal exits the alpha pathway to the ventricles and enters the refractory period, it also travels up the beta pathway, and by the time it reaches the alpha pathway again, that pathway is out of refractory. So now you have this reentrant loop set up that just keeps going and going, and every time around it causes both an atrial and a ventricular contraction, which again, just like AVRT, leads to high ventricular rates. This particular setup, where it goes down the slow pathway, or interrograde, and up the fast pathway, or retrograde, is called slow-fast AVNRT, or typical AVNRT. It's also possible to have the opposite, though, called fast-slow AVNRT, or atypical AVNRT, which, as the name suggests, is a lot less common than slow-fast AVNRT. With this type, the pathway goes down the fast pathway, or interrograde, and up the slow pathway, or retrograde. The tachycardia with AVRT and AVNRT typically doesn't last very long, and both are rarely life-threatening. They can, though, both produce symptoms like palpitations, shortness of breath, and feelings of dizziness, as well as syncope or fainting, in rare cases. With an ECG, the P wave is a signal from atrial contraction, and the QRS is the signal from ventricular contraction. On an ECG with AVNRT, the P wave might not be visible, since the signal's getting to the atria and the ventricles at almost the same time. So the P wave starts essentially where the QRS starts, and when you add them together, the P wave can get buried under the QRS complex. With AVRT, the P waves might or might not be buried, depending on where the accessory pathway is located. The definitive treatment for either AVRT or AVNRT is radiocatheter ablation, essentially destruction of the accessory pathway with AVRT, and destruction of the slow or alpha pathway with AVNRT. For AVNRT, sometimes people can use vagal maneuvers as well, which are ways to activate the vagus nerve, which tends to block the AV node temporarily, therefore potentially stopping the episode. Some methods include a corroded sinus massage as well as a Valsalva maneuver, which is forced exhalation against a closed airway. Also, they might use medication to slow AV node conduction. In rare cases where other treatments haven't been effective, though, they might need cardioversion. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel or telling your friends about us on social.
Peggy is a 68-year-old woman who comes to see you with skin changes on her left lower leg. On examination, Peggy has a low-grade fever and the left lower leg is erythematous, mildly swollen and hot to touch. you diagnose cellulitis as Peggy is penicillin allergic, you prescribe a course of clarithromycin. Peggy comes to see you 1 week later with new palpitations. Which of the following side effects of these antibiotics can be seen on an ECG? What does clarithromycin cause? I don't know. Does it block sodium? Maybe prolonged QT interval. Was this what happens in TCA overdose? I'm just guessing that clarithromycin might have a similar effect. Totally don't know this question. Yeah, it's correct. Macrolides may cause prolongation of QT interval. The options listed QT interval prolongation can be caused by macrolides. Palpitations are also listed as an uncommon side effect of macrolides. A prolonged PR interval indicates delayed conduction of the SA node impulse to the ventricles and is called first-degree AV block. Prominent P waves are caused by right atrial enlargement. The principal cause is pulmonary hypertension due to chronic lung disease called pulmonary tricuspid stenosis, congenital heart disease, pulmonary stenosis, tetralogy failure, or primary pulmonary hypertension. A shortened PR interval suggests pre-excitation, the presence of an accessory pathway between the atria and ventricles, which includes syndromes such as Wolff-Parkinson's White syndrome, or it could also suggest AV nodal junction rhythm. T-wave flattening has multiple causes, including ischemia, hypokalemia, and hypocalcemia. Macrolides. So we know that TCAs cause prolonged QT, prolonged QRS complex due to sodium blockade. So how does macrolides cause? How do macrolides cause QT prolongation? This is not surprising, as structurally similar macrolides have also been shown to cause QT interval. The mechanism by which clarithromycin induces QT prolongation is thought to be through the inhibition of the rapidly activating delayed rectifier potassium current in cardiac myocyte. Inhibition of the rapidly activating delayed rectifier potassium current in cardiac myocyte. So I'm guessing it's in the phase. This phase 0 is sodium influx, then potassium efflux. So in the phase 1 is blocked. Okay, good enough for me. A little bit too detailed. At least I can remember something. 30-year-old woman is admitted to hospital with abdominal pain and diarrhea. She has no past medical history other than depression, for which she takes citalopram, which is an SSRI. She smokes 20 cigarettes a day and drinks 20 units of alcohol per week. Ileocolonoscopy shows features consistent with Crohn's disease, and she is treated successfully with glucocorticoid therapy. Which of the following is the most important intervention to reduce the chance of further episodes? So she has Crohn's. Okay, you need to stop smoking, right? It's like the trigger for Crohn's. Other than that, medication wise, Crohn's responds well to aminosalicylates such as mesalazine, I think. But stopping smoking is the main thing, I think. Yeah. Crohn's disease is a form of inflammatory bowel disease. It commonly affects the terminal ileum and colon, but may be seen anywhere from mouth to anus. Patients should be strongly advised to stop smoking. Some studies suggest an increased risk of relapse secondary to NSAIDs and the combined oral contraceptive pill, but the evidence is patchy. Inducing remission. In inducing remission, you can use glucocorticoids, oral, topical, intravenous, generally used to induce remission. Budesonide is an alternative in a subgroup of patients. Enteral feeding with elemental diet. 5-ASA drugs, azathioprine, mercaptopurine, methotrexate, infliximab, metronidazole. Maintaining. Stop smoking is a priority. Remember, smoking makes Crohn's worse but may help ulcerative. That doesn't make sense. Azathioprine or mercaptopurine is used first line to maintain remission. Methotrexate is used second line. 5-ASA drugs, methotrexate should be considered if a patient had previous surgery. Let's look at nice guidelines for Crohn's disease. So we have the interactive flow chart. You have inducing remission for Crohn's, enteral nutrition for children and young. What's enteral nutrition? Enteral nutrition, one type of tube can be placed through the nose into the stomach or small intestine. The tube is called nasogastric nasoenteral feeding tube. Let's see what do they do. Medical and surgical treatments for Crohn's disease are associated with toxic effects. Medical therapy aims for mucosal healing and is achievable with biologics, immunosuppressive therapy, and specialized enteral nutrition, but not with corticosteroids. Sustained remission maintains a therapeutic challenge. Enteral nutrition containing macro and micronutrients is nutritionally complete and is provided in powder or liquid form. Enteral nutrition is a low-risk and minimally invasive therapy. It is well established and recommended as first-line induction therapy in pediatric Crohn's disease with remission rates of up to 80%. Other than in Japan, enteral nutrition is not routinely used in the adult population among Western countries, mainly due to unpalatable formulations which lead to poor compliance. This study aims to offer a comprehensive review of available enteral nutrition formulations and the literature supporting the use and mechanisms of action of enteral nutrition in adult Crohn's disease patients in order to support clinicians in real-world decision-making when offering or accepting treatment. The mechanisms of action of enteral feed, including their impact on the microbiome, were explored. Barriers to the use of enteral nutrition, such as compliance and the route of administration, were considered. All available enteral preparations have been comprehensively described as a practical guide for clinical use. Likewise, guidelines are reported and discussed. About 115,000 people in the UK have Crohn's disease. Up to a third of patients are diagnosed during adolescence, leading to many years of disease and associated morbidity. Half of these patients will require surgery during the natural history of their disease, and more than 75% of those will undergo further surgery. Complications such as stricturing or penetrating disease with fistula and abscess formation occur in a significant proportion of patients. Genetic and environmental factors affect CD phenotypes. CD phenotypes in childhood are more aggressive than when the disease arises in adulthood. In the last 2 decades, many drugs have been developed to treat Crohn's disease, and a top-down approach is now favored to achieve sustained clinical remission and resection-free survival for patients with Crohn's disease. Many patients do not respond to currently available treatments, immunosuppressants, biologics, and corticosteroids, or have an initial response that is not sustained. Efficacy also differs in therapeutic range and is administered in naive patients with newly diagnosed Crohn's disease or after failure or loss of response to other treatments. Treatments are associated with important toxic effects such as infections or even malignancy risks. The goals of Crohn's disease therapy include mucosal healing, which affects the natural history of the disease, but also avoidance of complications and improvement of quality of life, and are achievable with biologics, immunosuppressive therapy, and specialized enteral nutrition, but not with corticosteroids. sustained remission remains a therapeutic challenge. Course of treatment, particularly in the context of a top-down approach, may prohibit access to therapy for patients in many countries where there is no central funding. Exclusive and partial enteral nutrition. Enteral nutrition (EN), containing macro and micronutrients, are nutritionally complete, high-energy artificial nutritional supplements in powder or liquid form. Exclusive enteral nutrition provides 100% of daily nutritional requirements from a liquid nutrition formula, either orally or via a feeding tube. When 35 to 50% of habitual food intake is replaced with artificial enteral nutrition, such as oral nutritional supplements (ONS), it is known as partial enteral nutrition. Enteral nutrition is low-risk, non-invasive therapy. It is well established and recommended as the first-line induction therapy in pediatric Crohn's disease, with remission rates of up to 80%. Other than in Japan and increasingly in China, enteral nutrition is not routinely used in the adult population in Western countries, mainly due to unpalatable formulations that lead to poor adherence. In the 1970s, Voitk et al. Described the value of enteral nutrition in improving nutritional status, support value, and inflammatory markers, therapeutic value, in active inflammatory bowel disease. Despite the advances made in Crohn's disease algorithm therapy and increased interest in nutritional-based treatments, the role of enteral nutrition is still undetermined and is rarely recommended by gastroenterologists as first-line therapy. As such, enteral nutrition is underutilized. Additionally, the optimal formulation or diet to follow during PEN. What is PEN? PEN, partial enteral nutrition. Additionally, optimal formulation or diet to follow during partial enteral nutrition is still to be determined. Variation exists in the uptake of enteral nutrition worldwide, with Europe, Australia, and Canada showing higher use, particularly in the pediatric population, while the uptake remains low in adults. Enteral nutrition has been used prior to elective surgery. In order to reduce surgical complications, it has been reported to downstage the need for urgent surgery and reduces post-operative complications such as anastomotic leak or abscesses by reducing inflammation, improving nutritional status, and decreasing the antigenic load through bowel rest. Enteral nutrition has been used prior to elective surgery in order to reduce surgical complications. It has been reported to downstage the need for urgent surgery and reduces post-operative complications such as anastomotic leak or abscesses by reducing inflammation, improving nutritional status, and decreasing the antigenic load through bowel rest. Enteral nutrition has been shown to influence gut microbiome diversity, an important component of Crohn's disease pathogenesis, which may restore gut homeostasis and prolong remission, as well as improve our understanding about the etiology and trigger factors of Crohn's disease. However, dropouts in enteral nutrition trials are frequent due to unpalatable formulations and poor acceptance of a nasogastric tube. Enteral nutrition, basically you give a special formula milk that has all the macro and micronutrients that you get from a diet. Can be complete or partial. It's used to treat Crohn's disease in children. Because if you give glucocorticosteroids in children, it might stunt their growth slightly. Yeah, might end up shorter. Surgery for disease limited to the distal ileum. Consider surgery as an alternative to medical treatment early in the course of the disease for people whose disease is limited to the distal ileum, taking into account the following: benefits and risk of medical treatment and surgery, risk of recurrence after surgery. Full guidance contains observational data on recurrence rates after surgery, individual preferences, and any personal or cultural considerations. Record a person's views in their notes. Apheresis, interventional procedures. Nice published guidelines on leukapheresis for inflammatory bowel disease. Not much mentioned here. Drug treatment, monotherapy. Often monotherapy. This is inducing remission, right? Okay, so you can either induce remission through surgery or enteral nutrition. And now we're talking about monotherapy drugs. Often monotherapy with a conventional glucocorticosteroid, prednisolone, methylprednisolone, or IV hydrocortisone, to induce remission in people with a first presentation of single inflammatory exacerbation of Crohn's disease in a 12-month period. Consider budesonide for first presentation or single inflammatory exacerbation in a 12-month period for people who have one or more of distal ileocecal or right-sided colonic disease, and if conventional glucocorticosteroids are contraindicated or the person declines or cannot tolerate them. But budesonide is also a corticosteroid, glucocorticosteroid. Am I right? But this is inhaler. Therapeutic indication: mild, moderate, severe, persistent asthma. Is there other formulations of budesonide though? Nebulizer suspension. Therapeutic indication: bronchial asthma, pseudocroup. How about the other one? Medicines containing the active. Okay, never mind. Go back. How about this? Budenofolk. It's budesonide, but this one is a capsule. It's oral formulation, right? Capsule, gastro-resistant capsules. Budesonide for Crohn's disease. Okay, induction of remission in patients with mild to moderate active Crohn's disease affecting the ileum and or the ascending colon, microscopic colitis, autoimmune hepatitis. So let's see. Pharmacodynamics. Properties: is a glucocorticosteroid. The exact mechanism of budesonide in the treatment of Crohn's disease is not fully understood. Data from clinical pharmacological studies and controlled clinical trials strongly indicate that the mode of action of budenofolk 3 mg capsules is predominantly based on a local action in the gut. Budesonide is a glucocorticosteroid with a high local anti-inflammatory effect. At doses clinically equivalent to systemically acting glucocorticosteroids, budesonide gives significantly less HPA axis suppression and has a lower impact on inflammatory markers. So more of a local action than a systemic action compared to other glucocorticosteroids. But it's still a glucocorticosteroid. It's just not systemic, not as systemic as the others. Okay. Add-on treatment: consider adding azathioprine or mercaptopurine to a conventional glucocorticosteroid or budesonide to induce remission of Crohn's disease if there are 2 or more inflammatory exacerbations in a 12-month period, or the glucocorticosteroid dose cannot be tapered. Assess for TPMT activity before offering azathioprine or mercaptopurine. Do not offer azathioprine or mercaptopurine if TPMT activity is deficient, very low, or absent. Consider azathioprine or mercaptopurine at a lower dose if TPMT activity is below normal but not deficient according to local laboratory reference values. Consider adding methotrexate to conventional glucocorticosteroid or budesonide to induce remission in people who cannot tolerate azathioprine and mercaptopurine, or in whom TPMT activity is deficient if there are 2 or more inflammatory exacerbations in a 12-month period, or the glucocorticosteroid dose cannot be tapered. Drug treatment: biologic therapy. You have infliximab and adalimumab. When a person with Crohn's disease starting infliximab or adalimumab in line with NICE technology appraisal guidelines recommendation below, discuss options of monotherapy with one of these drugs or combined therapy, either infliximab or adalimumab, combined with an immunosuppressant. Tell the person there is uncertainty about the comparative effectiveness and long-term adverse effects of monotherapy and combined therapy, following recommendations from NICE technology appraisal guidance. Infliximab and adalimumab within their licensed indications are recommended as treatment options for adults with severe active Crohn's disease, whose disease has not responded to conventional therapy including immunosuppressive or corticosteroid treatments, or who are intolerant or have contraindications to conventional therapy. Infliximab or adalimumab should be given as a planned course of treatment until treatment failure, including need for surgery, or until 12 months after the start of treatment, whichever is shorter. People should have their disease reassessed to determine whether ongoing treatment is still clinically appropriate. Treatment, as described above, should normally be started with the less expensive drug, taking into account the drug administration costs, required dose, and product price per dose. This may need to be varied for individuals because of differences in the method of administration and treatment schedules. Infliximab, within its licensed indication, is recommended as a treatment option for people with active fistulating Crohn's disease whose disease has not responded to conventional therapy, including antibiotics, drainage and immunosuppressive treatments, or who are intolerant of or have contraindications to conventional therapy. Infliximab should be given as a planned course of treatment until treatment failure, including need for surgery, or until 12 months after the start of treatment, whichever is shorter. People should then have their disease reassessed. Treatment with infliximab or adalimumab should only be continued if there is clear evidence of ongoing active disease or determined by clinical symptoms, biological markers, and investigations including endoscopy if necessary. Specialists should discuss the risks and benefits of continued treatment with patients and consider the trial of withdrawal from treatment for all patients who are in stable clinical remission. People who continue treatment with infliximab or adalimumab should have their disease reassessed at least every 12 months to determine whether ongoing treatment is still clinically appropriate. People whose disease relapses after treatment is stopped should have the option to start treatment again. What about maintaining remission? There are options. Those who do not choose not to have it. Azathioprine or mercaptopurine as monotherapy to maintain remission, also offer azathioprine and mercaptopurine. Maintain remission in people who have not previously received these drugs. Consider methotrexate to maintain remission only in people who need methotrexate to induce remission, or have tried but did not tolerate azathioprine and mercaptopurine for maintenance, or have contraindications to azathioprine and mercaptopurine, for example TPMD activity or previous episodes of pancreatitis. So remission is with adalimumab, with azathioprine or mercaptopurine, but induction of remission can no role of aminosalicylate. Here first presentation, single inflammatory exacerbation. This kinds or tolerate them. Less effective than glucocorticosteroid. Okay. So for Crohn's, aminosalicylates don't play much of a role actually. Right. No mention about smoking. Yeah, smoking cessation. Give all people with Crohn's disease and their family members or carers information, advice, support in line with published NICE guidance on smoking cessation, patient experience, fertility. Okay, next question. A 54-year-old farm worker presents for review. She has recently been diagnosed with osteoarthritis of the hand but has no other past medical history of note. Despite regular paracetamol, she is still experiencing considerable pain, especially around the base of both thumbs. What is the most suitable next management step? You add ibuprofen? Yes? Or do you add diclofenac? These are both NSAIDs. Which one is more effective? And adding lansoprazole, which is a PPI, is gastroprotective. So I'm not sure ibuprofen or diclofenac, either one of these, which one is more effective. I'm gonna guess add with the PPI, no. The answer is add topical ibuprofen, not even oral ibuprofen. Okay. Osteoarthritis, give paracetamol plus topical NSAID if knee or hand. It's the first line. Okay. Let's look at NICE CKS. I think NICE CKS or NICE guidance. NICE guidelines. Do you have summary versions? Tools and resources. No summary versions. Okay, let's just look at the flowchart. Diagnosis, management, holistic approach, core treatments, patient information, exercise. Advise people with OA to exercise as a core treatment irrespective of age. Exercise should include local muscle strengthening, general aerobic fitness. Should be provided by NHS or the healthcare professional. Weight loss, offer prevention for weight loss. Exercise, patient, offer accurate verbal and written information, advise appropriate footwear. Okay, exercise and weight loss, yeah. Then pharmacological treatments. NICE intends to undertake a full review of evidence on the pharmacological management of osteoarthritis. It will start after a review by the MHRA on the safety of over-the-counter analgesics is completed. For more information, see the introduction to NICE guideline on osteoarthritis. In the meantime, the recommendation below remain current advice. However, the GDC Guideline Development Group would like to draw attention to the findings of the evidence review on the effectiveness of paracetamol that was presented in the consultation version of osteoarthritis guideline. The review identified reduced effectiveness of paracetamol in the management of OA compared with what was previously taught. The GDC believes that this information should be taken into account in routine prescribing practice until the planned full review of evidence on the pharmacological management of osteoarthritis is published. Oral analgesics. Healthcare professionals should consider offering paracetamol for pain relief in addition to core treatments. Regular dosing may be required. Core treatments include exercise and weight loss. Regular dosing may be required, but paracetamol and topical NSAIDs should be considered. Topical NSAIDs, okay, paracetamol and or topical NSAIDs, non-steroidal anti-inflammatory drugs, should be considered ahead of oral NSAIDs, which are COX-2 inhibitors, inhibitors. If paracetamol or topical NSAIDs are insufficient for pain relief for people with osteoarthritis, then the addition of opioid analgesics should be considered. Topical NSAID insufficient, opioid analgesics should be considered. Risks and benefits should be considered, particularly in older people. Topical treatments. Here, so consider topical NSAIDs for pain relief in addition to core treatments. For people with knee or hand osteoarthritis, consider topical NSAIDs and or paracetamol ahead of oral NSAIDs, COX-2 inhibitors, or opioids. Topical capsaicin should be considered as an adjunct to core treatments for knee or hand osteoarthritis. What's capsaicin? It's a cream, capsaicin, cream for topical application. Topical products for joint and muscular pain, capsaicin, similar agents. Although the precise mechanism of action of capsaicin is not fully understood, current evidence suggests that capsaicin exerts an analgesic effect by depleting and preventing reaccumulation of substance P in peripheral sensory neurons. Substance P is thought to be the principal chemical mediator of pain impulses from the periphery to the central nervous system. So, capsaicin, adjunct. NSAIDs and highly selective COX-2 inhibitors. Although NSAIDs and COX-2 inhibitors may be regarded as a single drug class of NSAIDs, these recommendations used two terms for clarity and because there are differences in side effect profile. When paracetamol or topical NSAIDs are ineffective for pain relief, for example, for people with osteoarthritis, then substitution of oral NSAIDs or COX-2 inhibitors should be considered. Where paracetamol or topical NSAIDs provide insufficient pain relief for people with osteoarthritis, then addition of oral inhibitor, COX-2 inhibitor to paracetamol should be considered. So either replace or ineffective. Okay, so if the previous thing is not effective at all, then you just replace it with oral NSAID. However, if it's insufficient, means that actually it's slightly effective but just not sufficient, then you add on instead of replacing. Use oral NSAIDs at the lowest effective dose for the shortest possible period of time when offering treatment with NSAIDs. The first choice should either be either a standard NSAID or COX-2 inhibitor, other than etoricoxib. In either case, co-prescribed with a PPI. All oral NSAIDs or COX-2 inhibitors have analgesic effects of a similar magnitude but vary in their potential gastrointestinal, liver, or cardiorenal toxicity. Therefore, when choosing the agent and dose, take into account individual patient risk factors, including age, when prescribing these drugs. Consideration should be given to appropriate assessment and ongoing monitoring of these risk factors. Persons with osteoarthritis need to take low-dose aspirin. Healthcare professionals should consider other analgesics before substituting or adding an NSAID or COX-2 inhibitor with a PPI if pain relief is ineffective or insufficient. Then you have intra-articular injections. Corticosteroid injections should be considered as adjunct to core treatments for relief of moderate to severe pain in people with osteoarthritis. Yep, okay. So mainly is first paracetamol, then topical NSAIDs, then if not effective at all, then you will replace with oral NSAIDs. However, if it's how to say, insufficient, means effective but not effective enough, then you would want to add an oral NSAID, and you consider morphine after that. Other than that, you can have intra-additional steroids. Yep. Okay. Topical first. Okay, OA, remember topical. Topical NSAIDs are indicated only for OA of knee or hand. Are you sure? Oh, sure. Really, only knee or hand, huh? It doesn't say here only knee or hand. There's one mention about knee or hand, but other than that, it also says topical first. But other than that, also knee or hand. Healthcare professionals should consider offering paracetamol pain relief in addition to core treatments. Regular dosing may be required. For core treatments as well, again, exercise and weight loss. Regular dosing may be required. Paracetamol and or topical NSAIDs should be considered ahead of oral NSAIDs. Okay, neck lumps. A 19-year-old man presents with swelling on the left side of his neck. On examination, smooth swelling in between the sternocleidomastoid muscle and the pharynx. This is a fluctuating but does not transmit or move during swallowing. Between sternocleidomastoid muscle and the pharynx. Just under the sternocleidomastoid then. What is this? Thyroglossus? Not thyroglossus. Pharyngeal pouch, right? Pharyngeal pouch. A 28-year-old Bangladeshi woman presents with 3-day history of sweats, headaches, lethargy, muscle aches. On examination, she has bilateral tender swellings on the submandibular region. Lymphoma, TB, Bangladesh, TB. Young. A 17-year-old girl presents with painless swelling in the neck. She is currently well. A midline cystic swelling is noted in the region of the hyoid bone. It moves upwards when she swallows or sticks her tongue out. Cystic swelling, huh? Thyroglossus cyst then. Oops. Oh man, branchial cyst. It's not pharyngeal pouch. Pharyngeal pouch is the one behind your, that thing that causes halitosis. It's called a branchial cyst. This thyroglossus cyst is correct. This is not tuberculosis. Probably has the flu. Here's your sweat, headache, lethargy, muscle aches. Okay, muscle aches. Point towards flu. Submandibular region. Tricked by the Bangladeshi. Okay. Muscle aches. Headache, lethargy, muscle aches. History of sweats, headache, lethargy, and muscle aches. Yeah, TB doesn't necessarily, it doesn't usually give headache. Muscle aches. Branchial cysts often present during intercurrent upper respiratory tract infection. What's a branchial cyst? An oval mobile cystic mass that develops between the sternocleidomastoid and the pharynx. Developed due to failure of obliteration of the second branchial cleft in embryonic development. Usually present in early adulthood. And what's the other cyst? Thyroglossus, no. Pharyngeal pouch. More common in older men. Represents a posteromedial herniation between the thyropharyngeus and cricopharyngeus muscles. It's cricopharyngeus. This thyropharyngeus is cricopharyngeus. Pharyngeal pouch comes out in between. Usually not seen, but if large, then a midline lump in the neck that gargles on palpation. Typical symptoms are dysphagia, regurgitation, aspiration, chronic cough. Okay. Most common cause of neck swellings, there may be a history of local infection, generalized viral illness. Okay, how would you describe the acid-base balance? A 25-year-old female presents with loin pain, frequency of micturition, and dysuria. Urinalysis reveals 3+ nitrites, 2+ leukocytes on examination, blood pressure 110, heart rate 120, temperature 38.4. ABG sample reveals BaO2 is higher than normal, PaCO2 is low. I think normal is 4.5 to 6, right? 4.5 to 6. pH is low as well. If pH is low, bicarbonate is low. So usually PaCO2, carbon dioxide, causes is acidic in nature. I mean, it's acidic in nature. So if you blow out carbon dioxide, usually it'll be in alkalosis. However, it's in acidosis. So there's a metabolic acidosis. And probably the low CO2 is respiratory compensation. Is it fully compensated or partially compensated? Look at the pH. pH is less than 7.35, so it's not fully compensated. It's metabolic acidosis with respiratory compensation, partial respiratory compensation. Yep. You're called to see a 75-year-old man with a history of Parkinson's disease who has just come back from surgery. 75-year-old, history of Parkinson's, just came back from surgery. He has been complaining of nausea and appears to be suffering from post-operative delirium. Which of the following drugs would be contraindicated? Nausea, appears to suffering post-op delirium. Okay, he has Parkinson's, he has post-op delirium. If he has Parkinson's, you want to avoid antipsychotics, right? Because antipsychotics block D2, and Parkinson's is a problem. Lack of dopamine transmission in the night striated pathway. So you give antipsychotics, you worsen the Parkinsonism. Can even cause them to be super stiff. Not good. So which one of this is an antipsychotic? Olanzapine is an antipsychotic. Will be contraindicated. Haloperidol is also an antipsychotic, so it should be contraindicated. Ondansetron is an antiemetic which acts on the chemoreceptor trigger zone. Lorazepam. Wait, between olanzapine and haloperidol, basically, right? Why? I think haloperidol is the typical antipsychotic which acts on D2 more strongly than olanzapine, which is the atypical, or how do you say, it acts on more receptors than just D2. So haloperidol will be more contraindicated compared to olanzapine, I think. Let's see. Yes. Haloperidol is contraindicated in patients with Parkinson's disease. Haloperidol is a dopamine antagonist that can worsen symptoms in those with Parkinson's disease and should be avoided. Despite being dopamine antagonist, domperidone does not easily cross the blood-brain barrier and is structurally considered safe for treating gastrointestinal symptoms in patients with Parkinson's disease because the risk of developing extrapyramidal side effects is considered minimal. Lorazepam is safe to use in Parkinson's disease. Olanzapine is an antipsychotic that's often used to treat delirium and is not contraindicated in Parkinson's disease. Ondansetron is an antiemetic which is safe to use in Parkinson's disease. Let me check the olanzapine. It is an antipsychotic, sure. Therapeutic indications: olanzapine, treatment of schizophrenia, maintaining clinical improvement during continuation therapy in patients who have shown an initial treatment response, indicated in treatment of moderate to severe manic episode. It's a psycholeptic, diazepine, oxazepine, pharmacodynamic effects. Olanzapine is an antipsychotic, anti-manic, and mood stabilizing agent that demonstrates a broad pharmacological profile across a number of receptor systems. In preclinical studies, olanzapine exhibited a range of receptor affinities, Ki less than 100 nanoM for serotonin, 5-HT2A, 5-HT3, 5-HT6, dopamine, D1, D2, D3, D45, cholinergic muscarinic receptors, M1 to M5, alpha-1 adrenergic and histamine receptors. Animal behavioral studies with olanzapine indicated 5-HT dopamine and cholinergic antagonism consistent with the receptor binding profile. Olanzapine demonstrated a greater in vitro affinity for serotonin than dopamine receptors and greater serotonin 2 than dopamine 2 activity in vivo models. Electrophysiological studies demonstrated that olanzapine selectively reduced the firing of mesolimbic dopaminergic neurons, while having little effect on the striatal pathways. Oh, I see, that's why it's not contraindicated in Parkinson's. Olanzapine reduced a conditioned avoidance response, a test indicative of antipsychotic activity, and thus doses below those producing catalepsy, an effect indicative of motor side effects. Unlike some other antipsychotic agents, olanzapine increases responding in an anxiolytic test. Higher serotonin than dopamine receptor occupancy. In addition, single photon emission computed tomography SPECT imaging showed a study in schizophrenic patients revealed olanzapine responsive patients had lower striatal D2 occupancy than some other antipsychotic and risperidone responsive patients, while being comparable to clozapine responsive patients. Cool. Very complex, blocks a lot of things. Domperidone, what's that used for? Domperidone is indicated for the relief of symptoms of nausea and vomiting. And how does it work? Domperidone is a dopamine antagonist with an antimetic properties. Domperidone does not readily cross the blood-brain barrier in domperidone users. Especially in adults, extrapyramidal side effects are very rare, but domperidone promotes the release of prolactin from the pituitary. Its antimetic effect may be due to a combination of peripheral gastrokinetic effects and antagonism of dopamine receptors in the chemoreceptor trigger zone, which lies outside of the blood-brain barrier in the area postremia. Animal studies, together with the low concentrations found in the brain, indicate predominantly peripheral effect of domperidone on dopamine receptors. Studies in men show oral domperidone to increase lower esophageal pressure, improve enteroduodenal motility, and accelerate gastric emptying. There is no effect on gastric secretion. In accordance with ICHE 14 guidelines, a thorough QT study was performed. This study included a placebo, active comparator, and positive control, and was conducted in healthy subjects with up to 80 mg per day, 10 or 20 mg administered 4 times a day or domperidone. This study found a maximum difference of QTC between domperidone and placebo. No clinical relevant QTC effect were observed. Okay. However, in two previous drug-drug interaction studies showed some evidence of QTC prolongation when domperidone was administered as monotherapy. Largest time match mean difference, blah blah blah. Okay. It's not proven to be active, not effective in children 12 years or younger. Okay. So domperidone is an antiemetic, blocks dopamine. The chemoreceptor trigger zone, which is in the area postremia, not covered by the blood-brain barrier, and main effect is peripheral dopamine antagonism causes increased gastric motility, such as similar to metoclopramide, I guess. Wait, what is metoclopramide? Dopamine antagonist as well, right? Metoclopramide, prevention of delayed chemotherapy induced nausea, radiotherapy induced nausea, vomiting. Action of metoclopramide is closely associated with parasympathetic nervous system control, upper GI tract, where the effect of encouraging normal peristaltic action provides a fundamental approach to control of this correlation with disturbed. Hey, what's the mention about dopamine? Contraindications: combination of levodopa or dopaminergic agonists. Strange. Doesn't mention about it in the pharmacodynamics. Oh well. A 45-year-old man with schizophrenia taking chlorpromazine is an antipsychotic as well, develops an oculogyric crisis. What side effect of antipsychotic medication is this an example of? This is acute dystonia. Yep. A 52-year-old Afro-Caribbean woman presents to the dermatology department. She has noticed a patch of pigmented skin on her toe, which has been slowly enlarging over the past 5 months. Pigmented skin on her toe. On examination, the pigmentation of nail bed of her great toe affecting the adjacent cuticle and proximal nail fold. Which subtype of melanoma would you expect to present in this manner? Oh. Is that a melanoma? Do I have a melanoma? I hope not. Acral. Acral means what? Amelanonic. What is acral? Acral means hands and feet. Lentiginous, what does that mean? Guess. Oh, correct. Acral, lentiginous. Okay, let's find what is acral. Acral, peripheral parts, limbs, fingers, ears. Okay. Acral comes from the Greek acros, end, extremity, peek. So hands and feet, fingers and toes lah. Acral lentiginous. Lentiginous, covered with resembling freckles, freckled. Lentiginous, covered with freckles. Freckled. Lentigo, freckle. What's a freckle though? I know the freckle on the face only. Freckle, small patch of light brown color on the skin, often become more pronounced through exposure to the sun. Acral lentiginous melanoma. Let's see some pictures. Acral lentiginous melanoma. It looks like that, huh? Okay, I don't have to worry then. Okay. Nail bed. Where is the nail bed? Below the nail. This is the nail plate. This is the nail blade. Oh, I see. Okay. Not where I thought it was. That is this area. Melanoma, Hutchinson sign. Rarest form of melanoma overall, but commonest form of melanoma in people with darker skin. Mostly affects people over the age, equally common in males and females. Not related to sun exposure, typically present enlarging discolored skin patch on the palms, fingers, soles, toes, characteristics of other flat forms of melanoma. It can arise in the nail unit, appearing as general discoloration or irregular pigmented bands surrounding longitudinal long nail plate. Subungual melanoma arises in the matrix. Subungual acral lentiginous melanoma in a important clinical clue. Hutchinson's nail signs extension of the nail bed, matrix, and nail plate pigmentation to the adjacent cuticle and proximal or lateral nail folds. Other forms of melanoma are now less likely to present in this way and are described in more detail in notes below. Most common is superficially spreading. 50-70% of cases typically affects arms, legs, back, and chest in young people. A growth moles, diagnostic features listing above. Growing moles, diagnostic features listed above. Okay, nodular, second commonest. Sun-exposed skin, middle-aged people. Red or black lump which bleeds or oozes. Lentigo, malignant. Less common. Chronically, sun-exposed skin, older people. Growing mole, diagnostic features listed above. Change size, change shape, change color, diameter more than 7. Oozing, bleeding, altered sensation, excision biopsy, this Breslov's thickness. How much you should resect the margin? For every 1 mm deepness, you should resect about 1 cm. About 1 cm of peripheral tissue. Cool. 47-year-old lady is referred by a GP with 2-day history of fever and headache. She is normally fit and well and has no past medical history of note. On examination, you note knuckle rigidity. Investigation show the following. Knuckle rigidity, meningitis, or any meningeal irritation. 2-day fever, history of fever and headache. Yeah, more likely meningitis. Serum glucose is 4.9. Lumbar puncture, opening pressure is 14. Is that normal? I don't know. Appearance cloudy. Okay, sounds like a bacterial meningitis so far. Glucose is 1.7. Less than half of the serum glucose. Sounds bacterial so far. Protein is 1.9. What's the normal? 0 to 1, is it? I need to find out what's normal range later. White cells 900. 90% polymorphs. Is this high white cells? What's the most likely infective agents? 47-year-old Streptococcus meningitis, Streptococcus pyogenes is the one that causes strep throat. Strep pneumoniae is the one that causes pneumonia. I think strep pneumoniae meningitis. Yeah. 6 years to 60 years age group are at risk of meningitis caused by strep pneumoniae. The CSF results are consistent with bacterial meningitis, low glucose, high protein, high polymorphs. This age group, Streptococcus pneumonia and Neisseria meningitis are the most common causes of bacterial meningitis. Here are the meningitis causes according to age group: 0 to 3 months GEL, GBS, E. coli, Listeria. 3 months to 6 years, NHS, Neisseria, Haemophilus, Streptococcus, pneumonia. 6 to 60 is NS, Neisseria, and Streptococcus pneumonia, more than 60, and SL, Listeria comes back. Immunosuppressed Listeria. Alright. I know what's meningitis. What do I want to find out? Oh yeah, normal values. Opening pressure. What's normal opening pressure? Normal range for CSF is reported differently. Various sources, most reporting normal range of 7 to 18 cmH2O. What's the unit here? CMCSF. Is CSF like almost like H2O, I guess. 10 to 20. 7 to 18. 10 to 20 easy to remember. Though some consider normal range of 5 to 25. Okay, I just remember 10 to 20. Pressure of more than 25, less than 5, should certainly prompt you to look for a source. 10 to 20, okay, 10 to 20. This is normal opening pressure. Appearance cloudy. Glucose, okay, less than half. Protein, normal protein. Normal protein range varies from lab to lab, but it's typically about 15 to 16 milligrams per deciliter, or 0.15 to 0.6 milligrams per milliliter. This is millimoles per liter. What is it in millimoles per liter? You should give normal ranges, realistically speaking, since it differs from lab to lab. And it's kind of a waste of brain space remembering numbers. Or else your job will just be taken over by computers if it's all about memorizing numbers, you know. CSF 3.3 to 4.4, is it? No, this is glucose. CSF protein here. Why is it mg per dl here? Okay, everywhere it says 0.15 to 0.6 milligrams per milliliter, mg per ml. 15 to 60 mg per dl. mg per dl to mmol per liter. But this is group blood. How about protein? Times 10 equals to mg per liter. Minimum. Man. Gram per liter. Protein, gram per liter. Protein. I don't know what unit is this. Protein. It doesn't even have protein. Oh, here. Mg per dl. Protein, gram per liter. How about here? Do you have reference values? Where are reference values? Oh, yeah. Okay, liver function, full blood count, other hematology, other biochemistry, ABG, lipids. You don't have normal value for CSF. Never mind, I give up. Normally they should give normal range. Don't give up. Come, that's fine. Normal protein levels. Normal protein levels. Glucose, protein, mean. What's this? Unit. Yeah, mg per dl. Yeah. Protein mg per dl. Nobody uses protein minimal per liter. Hello. How about Oxford Handbook? Glucose, CSF, white cell count. Protein mg per dl. Okay. Oh my gosh. Right back. Meningitis is under brain, right? Let's look for the brain picture. Here. Meningitis. Go to the first page, and you can see meningitis. No. Is it under infection though? It's not under neurology. Under infection. Here, infectious disease. Meningitis. No. Let's look for it from the index then. Meningitis 390456. Okay, let's see 390. 390 gram-negative bacteria. Oh well. How about 456? 456. Headache. Wow. Where's your CSF thingy, man? Meningitis. Meningitis 390456822 823. Okay. 822 and 823. Also, it's under emergency, is it? Yeah, okay. 822 823 meningitis. CSF. Protein grams per liter. Oh, grams per liter. Oh. Why am I looking for protein in millimole per liter when it's in gram per liter? Oh my god. What's wrong with me? Okay, protein in grams per liter. Bacteria is more than 1.5. Tuberculosis is 1 to 5. Viral is less than 1. So normal is less than 1. More than 1.5 is suggestive for bacteria. 1 to 5 is tuberculosis. Okay. Okay. Bovine cells. Close the page. 820 here. How about cell count per millimeter cube, right? 90 to 1000 is bacteria. Virus less than 1000. 50 to 1000. Tuberculosis 10 to 1000. Predominant cell in bacteria is polymorphs. 90% polymorphs. Probably predominant cell in virus mononuclear. Tuberculosis mononuclear as well. Lymphocytes as it can be. Okay. All right. Next question. You are seeing a woman with her 6-week follow-up appointment following normal vaginal delivery. She wishes to cease breastfeeding as her baby requires specialized formula feeds. Which medication can be used to suppress lactation in this case? Suppress lactation. What suppresses lactation? Dopamine suppresses lactation, right? Yeah, because antipsychotics block dopamine and has a side effect of lactation. So increased dopamine suppresses lactation. Which of these is a dopamine agonist? Misoprostol is a prostaglandin. Prostaglandin supposed to aid with lactation. No. T-lactase, I don't know what that is. Ursodeoxycholic acid is a bile acid stabilizer. Norhisterone, I don't know what that is. So that deals with cabergoline. Yes, cabergoline is the medication of choice in suppressing lactation when breastfeeding cessation is indicated. Cabergoline is a dopamine receptor agonist which inhibits prolactin production, causing suppression of lactation. Norhisterone is a progestogen. I should have known. Sounds like progesterone. Norhisterone is a progestogen. It has no effect on lactation. Misoprostol is used to soften the cervix in induction of labor. Ursodeoxycholic acid is a bile acid chelating agent used in cholestasis of pregnancy. T-lactase is a lactase enzyme supplement for people with lactose intolerance. Oh. Let's see, cabergoline. It's cabergoline. Therapeutic indication: inhibition of physiological lactation soon after delivery for suppression of already established lactation. After parturition, when the mother elects not to breastfeed the infant when breastfeeding is contraindicated due to medical reasons related to either mother or the newborn. After stillbirth or abortion, suppresses physiological activation by inhibiting prolactin secretion. I guess that's the other choices for treatment of hyperprolactinemic disorders. Maybe if you're spironolactone, right? Dopaminergic ergoline derivative, and down with a potent and long-lasting PRL lowering activity. It acts by direct stimulation of D2 dopamine receptors on pituitary lactose, thus inhibiting PRL prolactin secretion. In rats, the compound decreases prolactin secretion at oral doses of 3 to 25 micrograms per kg, and in vitro at a concentration of 45 picograms per ml. In addition, cabergoline exerts a central dopaminergic effect via D2 receptor stimulation at oral doses higher than those effective in lowering serum prolactin levels. Long-lasting prolactin lowering effect of cabergoline is probably due to its long persistence in the target organ, as suggested by the low elimination. Okay, a bit too much detail. Kind of close the reference range just now. A 34-year-old man comes to the GP for a review. Over the past 2 weeks, he has developed a number of painful erythematous lesions on his shins. Sounds like erythema nodosum. Painful erythematous lesions on the shin. He has no dermatological history of note and is usually fit and well. On examination, the lesions are consistent with erythema nodosum. You arrange some baseline investigations for the most appropriate management. How do you treat erythema nodosum? You want to treat the underlying cause, right? Do you want to treat it for cosmetic purposes? Then you would probably use oral prednisolone, I guess. Usually you treat the underlying cause. Arrange for routine follow-up because we want to find out what's causing the erythema nodosum. Or do you want to treat? It's painful. What if it's TB? You don't want to give immunosuppressant, right? Yeah, treat the underlying cause. Erythema nodosum overview. Inflammation of subcutaneous fat typically causes tender erythematous nodular lesions. Usually occurs over shins, may occur elsewhere, forearms, thighs. Hello, please give me an explanation. No explanation. Could be cancer. Baseline investigations. They're all trying to justify their own answers. No explanation, huh? Very unhelpful. Let's see if NICE has guidelines. Dermnet evidence.nhs search result means you don't have BAD. Guys, this one looks reliable. Common causes: throat infection, medication, sarcoidosis, inflammatory bowel disease, pregnancy. Symptoms, painful, whatever, look like. Diagnose. Recognizing rounded lumps of skin size, necessaries for skin biopsy occasionally. Removal of small sample of skin, additional investigation, blood test, chest x-ray, determine the underlying cause. Most patients with EN make a full recovery within a few weeks or months. However, in some patients, new lumps of EN may occur over several weeks, with the condition persisting and following a longer time course lasting for 6 months and occasionally longer. How is it treated? Your doctor will look for known triggers of EN. If an infectious cause is identified, then antibiotic treatment may be given. If a particular medication is suspected as a trigger, it may be stopped. For most people with EN, the rounded lumps tend to heal spontaneously. Some patients may need treatment to relieve symptoms such as bed rest, leg elevation, anti-inflammatory painkillers, and SIDS. For more prolonged EN, a number of stronger treatments may be used, such as steroid tablets. Yeah. Okay. Most of the time it's not treated then. Next question. A 33-year-old lady presents for pre-op assessment 4 weeks before elective ankle surgery. She will be immobilized for a minimum of 10 days following her surgery. What is the correct information to tell the patient regarding a combined oral contraceptive pill prior to surgery? You're gonna stop it before surgery. Well, how long before surgery should you stop it? 2 weeks. Stop in 2 weeks. Stop immediately. Wait, 4 weeks before. So stop. When should you stop? Should you stop 2 weeks before surgery or 4 weeks before surgery? And you wanna use barrier, right? I'm gonna assume 2 weeks before surgery, and I'm gonna say barrier because it doesn't involve any hormones. No! Stop immediately, so you need to stop at least 4 weeks before surgery. Okay, estrogen containing contraceptives should preferably be discontinued 4 weeks before major elective surgery, and all surgery to the legs or surgery which involves prolonged immobilization of a lower limb. A progesterone-only contraceptive may be offered as an alternative, and the estrogen-containing contraceptive restarted after mobilization. These recommendations do not apply to minor surgery with short duration of anesthesia, for example laparoscopic sterilization or tooth extraction, or to women using estrogen-free hormonal contraceptives. Okay, at least 1 month before you have to stop it. Okay. Easy to remember that 1 menstrual cycle before. Okay, next question. A 65-year-old man presents to the emergency department. He has a history of hypertension, diabetes, obesity, osteoporosis. On inspection, appears generally unwell. Temperature 38.6, fever, blood pressure is low, septic shock maybe, heart rate of 104. Closer examination, small foul-smelling necrotic ulcer on the base of his penis with a large area surrounding erythema. What's going on? He's extremely tender beyond the borders of erythema. Which of the following medications would predispose him to this presentation? Okay, so he has diabetes. SGLT2 inhibitors would increase the risk of genital infection, which is what he is having here. So which one of these is an SGLT2 inhibitor? Gliflozin, right? SGLT2 inhibitors have been linked to necrotizing fasciitis of the genitalia or perineum, Fournier's gangrene. It's a horrible condition. Necrotizing fasciitis. Okay, next question. 50-year-old woman presents to the emergency department with generalized abdominal pain and bilious vomiting, worsening over the course of 3 days. She has not passed stool in this time and has lost appetite. She drinks 2 units of alcohol a week and has no significant past medical history apart from elective hysterectomy 3 years ago for fibroids. HB is lower limit of normal. Platelets normal, white blood cells. What's normal for white blood cell? 3 to 11, is it? 4 to 11. So this is high. Sodium is lower than normal, potassium normal, urea normal, creatinine normal. Serum amylase. What's the normal amylase? Anyway, am I thinking of amylase? Am I thinking of pancreatitis? No, right? Thinking of abdominal pain and vomiting, bilious vomiting, no stool pass. Sounds like a small bowel obstruction, especially she has a previous surgery before. Let me just look at the normal value of serum amylase. It's not given here, is it? No, it's not given here. It's not given here. Here, amylase. Normal is 70 to 300. Slightly raised amylase. Not very suggestive for pancreatitis. Usually more than 3 times the normal range, then you would suspect pancreatitis. What else do I want to know? Well, it sounds like a small bowel obstruction, and it is. So amylase level can rise in small bowel obstruction, not just pancreatitis. No surgery, no follow. Okay. Amylase can be raised in any of the following reasons: infection, mumps, intra-abdominal pathology, perforation, peptic ulcer, bowel, intestinal obstruction, pancreatitis, drugs, morphine, renal failure, congenital hyperammonemia. Pancreatitis is the most common cause, but often presents with serum amylase at least 4 times the upper limit. Oh, I was thinking 3 times the upper limit. Next question. 16-year-old girl presents to GP complaining of heavy menstrual bleeding that affects her day-to-day activities. She reports that on her first day of her period, she would go through a full box of tampons. She has read on a patient pamphlet that menorrhagia is characterized by abnormally heavy bleeding experienced during menstruation. Before making the diagnosis of menorrhagia, her GP checks the diagnostic criteria. What definition is used to classify bleeding? Oh, this is a stupid classification, because nobody actually measures the amount of blood. But the new one says the amount that woman considers to be excessive, right? Right? Or is it? Oh, are you trying to? You want the official definition, or do you want the one that we use clinically? Clinically, I guess. Yeah. The definition of menorrhagia has changed. Oh, okay, so it's a new one to reflect a woman's subjective experience rather than trying to quantify blood loss. Heavy bleeding in menorrhagia was previously defined as a total amount of blood loss more than 80 ml for the duration of the menstrual cycle. However, the definition of menorrhagia has changed to reflect a woman's subjective experience rather than trying to quantify blood loss. The shift from a quantitative to qualitative definition of menorrhagia has been driven by difficulties in measuring actual blood loss, and also because treatment to reduce heavy menstrual bleeding can result in quality of life improvement regardless of the actual amount of blood loss. Makes sense. A 72-year-old patient on the geriatric ward has suffered a fall. He has a CT hit. The report is as follows. There's a very large acute right subdural hematoma which is causing significant mass effect and midline shift from right to left. The lateral ventricles are significantly displaced to the left side, and there's significant uncal herniation. Doesn't look good at all. On examination, the patient's right pupil, from the right to left, so the uncal herniation is on the right, I guess, dilated because of compression to the third nerve, compression on the parasympathetic outer part of the third nerve, block parasympathetic, you will have oversympathetic, sympathetic cause of pupillary dilation, okay, unresponsive to light. A consensual response is presented in the left pupil, so cranial nerve 2 is still intact. There is also a ptosis on the right side, yeah, because cranial nerve 3 is fully compressed. What cranial nerve is most likely to have been affected? Third cranial nerve. Okay, raised ICP can cause the cranial nerve due to herniation. Next, a 64-year-old with recently diagnosed type 2 diabetes presents to his GP. He was started on metformin 500 mg once daily 2 weeks ago. Since then, he has reported severe diarrhea, which is affecting his quality of life. What is the most appropriate next step in management? Recently diagnosed T2DM, started metformin once daily 2 weeks ago. Since then, it's reported severe diarrhea. Okay, so because this is the normal kind of metformin, you want to try the modified release one first, the slow release. So switch to metformin, modified release. Yep. Okay. Next question. 67-year-old female taken to the emergency department by her daughter. She appears very confused, which is out of character for her. Her daughter stated that earlier on in the day her mother was complaining of headache and mild nausea. While in the emergency department, her Glasgow Coma scale drops and she starts to have a seizure. Her blood results show hyponatremia. Which one of the following is the cause of hyponatremia? Okay, let's see. SIADH is a cause of hyponatremia. You reabsorb too much water, you dilute your blood of sodium, hyponatremia occurs. Let's look at others. Cushing's disease. Cushing's is too much cortisol. Hypercortisol causes sodium absorption. You wouldn't have hyponatremia. Diabetes insipidus is like the opposite of SIADH in the sense that your kidneys either don't respond to ADH or your pituitary doesn't secrete enough ADH. So if this happens, not enough ADH, you cannot concentrate your urine, you cannot reabsorb water. If you cannot reabsorb water, you have hypernatremia instead of hyponatremia. ACE inhibitor side effects? No, I don't think so. ACE inhibitor, ACE, but ACE converts angiotensin 2. Right, angiotensin 2 to aldosterone, I think, something like that. And then aldosterone is responsible for reabsorbing sodium. So ACE inhibitor can theoretically cause hyponatremia, right? If you inhibit conversion into aldosterone, you inhibit sodium reabsorption. Yeah. Theoretically, it could cause hyponatremia. Primary aldosteronism. Aldosterone causes sodium absorption, so definitely not, it's the opposite. I don't know about ACE inhibitor, but I know SIDH definitely can cause hyponatremia. ACE inhibitors are not a recorded cause of hyponatremia. However, diuretics are a known cause. Really? It's not a recorded cause. Let's look at the Remipil. Yeah, it has a potential risk of hyponatremia. So this question is flawed. ACE inhibitor is a potentially correct answer as well. Next question. 65-year-old lady presents to emergency department late at night, complaining of new onset dizziness and shortness of breath on exertion. 65-year-old lady presented emergency department late at night complaining of new onset dizziness and shortness of breath on exertion. On further questioning, she also reveals that her stools have been quite unpleasant and a lot darker than usual. Sounds like Melina. She might have anemia causing this dizziness and shortness of breath. Her blood test revealed normocytic anemia and a raised urea level, so it's an upper GI bleed most likely. You suspect that she has an acute upper GI bleed, okay? You book an endoscopy for the following morning and consider prescribing a PPI to alleviate her symptoms overnight. Which of the following is the most appropriate action with regards to her further management? I thought before endoscope you shouldn't give PPI, I'm not sure. I have to go and study about that. Most appropriate action in regards to further management. Give omeprazole, commence omeprazole, give oral lansoprazole, give oral pantoprazole, do not prescribe PPI. Do not prescribe PPI, I think. Yeah. PPI should not be administered as part of the acute management of upper GI bleeding prior to endoscopy. PPI should not be prescribed in acute GI bleed unless post-endoscopy, as they may mask the site of bleeding. Go to overview, flow chart. Initial management. Transfuse patient with massive bleeding with blood, platelets, and clotting factors in line with local protocols for massive bleeding. Base decision on blood transfusion on full clinical picture, recognizing over-transfusion may be as damaging as under-transfusion. Do not offer platelet transfusion to patients who are not actively bleeding and are hemodynamically stable. Offer platelet transfusion to patients who are actively bleeding and have a platelet count less than 50. Offer fresh frozen plasma to patients who are actively bleeding and have prothrombin time or INR or activated APTT time greater than 1.5 times of the normal. If a patient's fibrinogen level remains less than 1.5, offer cryoprecipitate as well. Offer prothrombin complex concentrate for patients who are taking warfarin and actively bleeding. Treat patients who are taking warfarin. Has stopped in line with local warfarin protocols. Detecting oral anticoagulants, controlling bleeding, preventing bleeding. Continue low-dose aspirin for secondary prevention of vascular events in patients with upper GI bleeding and homeostasis. Hemostasis has been achieved. Stop other non-NSAIDs, including COX-2 inhibitors, during the acute phase in patients presenting with upper GI bleeding. Discuss recent benefits of continuing clopidogrel in patients with upper GI bleeding with the appropriate specialists, for example, cardiologist or stroke specialist, and with the patient. Risk assessment, Batchford score, first assessment. Use the following formal risk assessment scores for all patients with acute upper GI bleeding. The Blatchford score, the full Rocco score after endoscopy. Blatchford score stratifies upper GI patients who are low risk and candidates for outpatient management. So it's the risk, how to manage. Determines severity of GI bleeding, okay? That's you just need to know. It's a risk stratification thing. Blatchford and Rocco. Blatch, bleeding, Blatchford. Rockall score. After endoscopy. Offer endoscopy to unstable patient with severe acute upper GI bleeding immediately after resuscitation. Offer endoscopy within 24 hours of admission to all other patients with upper GI bleeding. Units seeing more than 330 cases should arrange their service according to local circumstances. Okay. If it's non-varicose bleeding, endoscopic treatment. Do not use adrenaline as monotherapy for the endoscopic treatment of non-varicose upper GI bleed. For the endoscopic treatment of non-varicose upper GI bleed, use one of the following: a mechanical method, for example, clips with or without adrenaline, thermal coagulation with adrenaline, fibrin or thrombin with adrenaline. PPI. Do not offer acid suppression drugs before endoscopy to patients with suspected non-varicose upper GI bleed. Offer PPI to patients with non-varicose upper GI bleed and stigmata of recent hemorrhage shown at endoscopy. You can clip, or you can cauterize, or you can give fibrin or thrombin with adrenaline. Endoscopic treatment. So I guess you inject it locally. Treatment after first or failed endoscopic treatment. Consider repeat endoscopy with treatment as appropriate for all patients at high risk of rebleeding, particularly if there is doubt about adequate hemostasis at the first endoscopy. Offer repeat endoscopy to patients who rebleed with a view to further endoscopic treatment or emergency surgery. Offer interventional radiology to unstable patients who rebleed after endoscopic treatment. Refer urgently for surgery if interventional radiology is not promptly available. Varicose bleed. Offer telepressin also. Okay, so everything you do here, if it's major bleeding, you're gonna give blood products, right? And you wanna arrange endoscopy. If it's not varicose, then you can give PPI, and you can treat endoscopically. Either you clip it, or you burn it, or you inject some, what's that again? Fibrin or thrombin. Then if it's a varicose bleed, you want to give terlipressin. This constricts the vessels there. Offer terlipressin to patients with suspected varicose bleeding at presentation. Stop treatment after definitive hemostasis has been achieved after 5 days unless there is another indication for its use. Offer prophylactic antibiotic therapy at presentation to patients with suspected or confirmed varicose bleeding. Prophylactic antibiotic therapy. Stop treatment after definitive hemostasis achieved or after 5 days. If it's gastric varices, offer endoscopic injection of N-butyl-2 cyanoacrylate to patients with upper GI bleeding from gastric varices. Offer TIPS, transjugular intrahepatic portosystemic shunts, if bleeding from gastric varices is not controlled by endoscopic injection. Esophageal varices, use band ligation in patients with upper GI bleeding from esophageal varices. Consider tips. Okay. Cool. A 70-year-old woman presents with gradual onset proximal shoulder and pelvic girdle muscular pains and stiffness. 70-year-old woman gradual onset proximal shoulder and pelvic girdle muscle pains and stiffness. She is finding it increasingly difficult to get dressed in the morning and is unable to raise her arms above the horizontal. Looking at the notes, you realize she's on atorvastatin 20 mg for primary prevention and recently completed a course of clarithromycin for... Oh, okay. So atorvastatin plus clarithromycin for lower respiratory tract infection, penicillin allergic. You subsequently arrange for her to undergo some blood tests, results which are below. HB is low, white blood cell normal for her gender, white blood cells slightly high, platelets normal, sodium normal, potassium normal, urea normal, creatinine normal. So it's not rhabdomyolysis. Bilirubin normal, ALP normal, ALT normal, GGT normal, albumin normal. CRP is very high, ESR is very high, creatinine kinase is normal. So it's not rhabdomyolysis as I thought, because it's not statin plus clarithromycin. In this case, it's more likely a rheumatologic condition. CRP is very high. Polymyalgia rheumatica. Right? Pain and stiffness. Polymyalgia rheumatica. Demographic 70-year-old woman.
With polymyalgia rheumatica, poly means many, mya means muscles, and algia means pain. Rheumatica comes from rheumatism, which broadly refers to conditions that affects the joints and connective tissue. So polymyalgia rheumatica is a disorder that causes muscle pain and joint stiffness. It's considered to be an immune-mediated disease, meaning that the immune system attacks our own body. It's important to note that although myalgia means muscle pain, the muscles are usually spared and it's the tissue around the joints that mostly gets inflamed. Normally, the cells of the immune system are always hanging around, ready and excited to spot and fight against anything foreign that could cause harm inside the body. One particular type of immune cell, the dendritic cell, is a type of antigen-presenting cell, meaning that it grabs a pathogen, for example a bacterium, destroys it, and presents a part of that bacterium called an antigen to other immune cells. Dendritic cells take their name from the fact that they have branch-like arms called dendrites, which help them grab antigens. Dendritic cells take their captured antigen and move over to a nearby lymph node, where they present the antigen to a helper T cell. Dendritic cells present the antigen on a protein called a major histocompatibility complex, or MHC class II molecule, which is on their cell surface. MHC class II molecules are like a serving platter, which holds the antigen as it gets presented to the helper T cells. Once these antigens are recognized as foreign, T helper cells get activated and start secreting a lot of pro-inflammatory cytokines, or signaling molecules. Those then recruit more immune cells, like macrophages, to the site of inflammation. At the same time, other cytokines, called interleukins, trigger B cells to secrete antibodies against the targeted antigens. These antibodies block pathogens from causing harm, and also tag them so that other immune cells, like macrophages, can recognize and destroy them. Although the exact cause of polymyalgia rheumatica is not well understood, it's associated with both genetic and environmental factors. For example, a person with a certain gene for an MHC class II molecule, also called a human leukocyte antigen, or HLA-DR4, is more likely to develop the disease, especially after an infection with adenovirus or parvovirus B19. This might be due to a process called molecular mimicry, which is where an immune cell mistakes a protein in the body for being a foreign protein. When our own proteins trigger an immune response, the protein is called an autoantigen. So these autoantigens get picked up by antigen-presenting cells, which go on to activate helper T cells. These helper T cells in turn activate B cells, which start producing antibodies against the autoantigens. Then both helper T cells and antibodies enter the circulation and reach the large joints, like the shoulder and hip. Once there, they secrete cytokines like interferon gamma to recruit more immune cells like macrophages. Macrophages head over to those joints and produce inflammatory cytokines, like tumor necrosis factor alpha, or TNF-alpha, interleukin 1, and interleukin 6, which together with the T cell cytokines promote inflammation of the joint lining. Now, although it's called polymyalgia, the muscles themselves are not inflamed and actually appear normal on biopsy. Instead, the pain comes from structures surrounding the joints, like the tendons and bursae, rather than the joints themselves, and that affects nearby nerves in the muscle, called referred pain. Meanwhile, these inflammatory cytokines travel through the bloodstream and reach other organs. For example, interleukin 1 and interleukin 6 travel to the brain, where they act as pyrogens, inducing fever. In fact, polymyalgia rheumatica is also strongly associated with giant cell arteritis. That's a condition where there's inflammation of the walls of the arteries in the temples, which is why it's also called temporal arteritis. Polymyalgia rheumatica often affects women over 50 years of age, and typically causes symptoms like pain and stiffness of the shoulder and hip, which often starts on one side but typically progresses to both sides within weeks. The symptoms are usually more severe in the morning and at night, often lasting for more than an hour, and they typically improve after activity. The pain can make it hard to get out of bed or up from a chair, and lifting the arms above shoulder height can be tough. It can also cause a low-grade fever, fatigue, and loss of appetite, which can lead to weight loss. Also, many people can develop temporal arteritis, which causes symptoms like severe headache, jaw pain, and vision problems, and even blindness. The diagnosis of polymyalgia rheumatica can be confirmed by increased inflammatory markers, like a high erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP. Since there's little damage to the muscles, muscle enzymes like creatine kinase usually remain normal, which distinguishes polymyalgia rheumatica from other inflammatory muscle disorders, like polymyositis. Treatment of polymyalgia rheumatica focuses on suppressing the immune response, usually with low doses of corticosteroids, like prednisone. Specific exercises and a healthy diet can also help strengthen the muscles and bones, as well as improve flexibility of affected joints. Alright, as a quick recap. Polymyalgia rheumatica is an inflammatory disorder that causes pain or stiffness, usually in the shoulders and hips, and is commonly associated with temporal arteritis. There's usually an elevation in inflammatory markers, but the creatine kinase is usually normal, which distinguishes it from other inflammatory muscle disorders, like polymyositis. Video on this topic, let's jump straight to the condition that causes pain. Polymyalgia rheumatica is an inflammatory condition that causes pain and stiffness in the shoulders, the pelvic girdle, and the neck. There are strong associations with giant cell arteritis, or temporal arteritis, and the two conditions often occur together. Both conditions respond very well to treatment with steroids. There's very good, nice clinical knowledge summaries on polymyalgia rheumatica, and I suggest you read them before treating patients. However, there's a summary here just to help with your learning and your revision. So with PMR, it's very important to talk about the demographics of the patients that are affected. It usually affects older adults above the age of 50 years. It's more common in women and also more common in Caucasians. So in your exam, the typical patient will be around 60 years old, female, and white. So what are the core features? Well, the clinical knowledge summaries from NICE give us some core features that can be used to determine which patients have polymyalgia rheumatica, and these features should be present for at least 2 weeks before we make the diagnosis. Firstly, there'll be bilateral shoulder pain that may radiate to the upper arms and down to the elbow. Bilateral pelvic girdle pain, so this is pain throughout the whole pelvic girdle and hips. The pain is worse with movement. It interferes with sleep, and there's profound stiffness in these joints, which typically lasts at least 45 minutes in the morning before they're able to get the joints moving and loosened up. Some other features are systemic symptoms like weight loss, fatigue, low-grade fever, and low mood. There can be some upper arm tenderness, carpal tunnel syndrome, and there may be pitting edema. So let's talk about the differential diagnosis. One of the key challenges is to exclude other conditions that can cause similar symptoms, and also not to miss other diagnoses. There's a long list of differentials of symptoms that can cause similar features, and some examples are osteoarthritis, rheumatoid arthritis, systemic lupus erythematosus, myositis or inflammation in the muscles due to conditions like polymyositis, dermatomyositis, or medications like statins, cervical spondylosis, or basically wear and tear in the cervical spine, adhesive capsulitis of the shoulders, hyper or hypothyroidism, osteomalacia, and fibromyalgia. So all of these conditions you need to think about in somebody presenting with these generic symptoms. So how do we establish a diagnosis? Well, the diagnosis is mainly based on clinical presentation and the response to treatment with steroids. Other conditions need to be excluded in order to make a diagnosis of polymyalgia rheumatica. Testing for inflammatory markers like ESR, plasma viscosity, and CRP can be helpful, and these are usually raised. However, normal inflammatory markers don't rule out polymyalgia rheumatica. The NICE clinical knowledge summaries advise a number of investigations prior to starting steroids to exclude other conditions, and this would include a full blood count, urea and electrolytes, liver function tests, a calcium, which can be raised due to hyperparathyroidism or cancer, or could be low in osteomalacia, serum protein electrophoresis, which is useful for screening for myeloma or other protein disorders, thyroid stimulating hormone to test for thyroid function, creatine kinase to test for myositis, rheumatoid factor to look for rheumatoid arthritis, and a urine dipstick. Some additional investigations you might want to consider are anti-nuclear antibodies to test for systemic lupus erythematosus, anti-CCP antibodies for rheumatoid arthritis, a urine Benz-Jones protein for myeloma, and a chest X-ray to look for lung pathologies like lung cancer, which might be associated with dermatomyositis, and also for mediastinal abnormalities. So how do we treat PMR, or polymyalgia rheumatica? Well, the mainstay of treatment is with steroids. And the NICE clinical knowledge summaries have clear guidelines on the steroid regime, which is worth following if you're treating patients. And this is a summary just to help with your understanding. So initially, patients are started on 15 milligrams of prednisolone per day. This is usually taken in the morning because steroids can boost your energy levels and also prevent you from sleeping if taken too late on in the day. You would assess the patient 1 week after starting steroids. And if there's a poor response in symptoms, it's probably not polymyalgia rheumatica, and you need to consider an alternative diagnosis and stop the treatment with steroids. You'd assess them again 3 to 4 weeks after starting steroids. And at this point, you would expect at least a 70% improvement in symptoms and also the inflammatory markers to return to normal. And if this is the case, you can make a working diagnosis of polymyalgia rheumatica. If at 3 to 4 weeks of treatment, there's been a good response, then you can start reducing the steroid dose using a reducing regime. And the aim is to eventually get the patient off the steroids. So you use 15 milligrams until the symptoms are fully controlled, then step down to 12.5 milligrams for 3 weeks, then 10 milligrams for 4 to 6 weeks, and then reduce by 1 milligram every 4 to 6 weeks after that. And if you find that the symptoms are reoccurring whilst on a reducing regime, they may need to increase the dose or stay on the dose longer before reducing again. It can take 1 to 2 years to fully wean the patient off steroids. If there's doubt about the diagnosis, or difficulty in controlling the symptoms, or difficulty weaning them off the steroids, or the steroids are required for more than 2 years, then it's worth referring them to a rheumatologist for specialist management. It's very important when somebody's on long-term steroids to implement some additional measures to protect them against the negative effects of steroids. And you can use the helpful mnemonic, "Don't stop," to remember these measures. Don't refers to making them aware that they will become steroid dependent after 3 weeks of treatment, and they shouldn't stop taking the steroids due to the risk of adrenal crisis if the steroids are abruptly withdrawn. And then stop is a mnemonic for S for sick day rules. So you need to discuss increasing the dose of steroids if they become unwell. T is for treatment card. So you need to provide a steroid treatment card, which they keep on them, that alerts other people that they're steroid dependent. For example, if they become unresponsive, paramedics or doctors can see the steroid treatment card and realize they may need a dose of steroids. O is for Osteoporosis Prevention, and you need to consider osteoporosis prophylaxis whilst on steroids, and this can be with bisphosphonates and calcium and vitamin D supplements, because long-term steroids thin the bones. And finally, P is for proton pump inhibitor, and steroids can cause irritation of the stomach lining and increased acid secretion, so consider gastric protection with a proton pump inhibitor such as omeprazole or lansoprazole. Thanks for watching this video. If you found it helpful, please consider giving it a thumbs up and subscribe.
Don't stop. You're giving long-term steroids. Don't stop. So don't suddenly stop your steroids after 3 weeks of initiating it, because you might have Addisonian crisis because you're dependent on it. S stands for what does S stand for again? Sick day rules. S stands for sick day rules, so you might need to take double the dose of steroids when you're having stomach upset, you're having fever or flu or whatever thing. T for, can't remember, treatment card. Sick day rules, treatment card. So you need to give them a treatment card to let paramedics or any medical professionals know that they are taking steroids. O stands for osteoporosis prophylaxis. You can give bisphosphonates, calcium, vitamin D supplementation. P stands for PPI, for stomach protection, right? Yeah. So in someone taking steroids, you need to tell them that they shouldn't suddenly stop taking the steroids because of risk of Addisonian crisis. You should tell them about sick day rules, where you need to take double the dose of the steroids in case you have a fever, flu, or you have a stomach upset. You need to give them a treatment card so that people know that they are on steroids and they can be aware of it. You need to give them osteoporosis prophylaxis. You can give them bisphosphonates or give them calcium, vitamin D supplementation, and you can give them PPI for gastric protection. I think we'll stop at 30. We aim for 100, but it's quite too much. Okay, so 3 more questions. A 59-year-old male presents to his general practitioner describing episodes of central chest tightness that are brought on by exertion and relieved by rest. His past medical history includes osteoarthritis, gastroesophageal reflux disease, gout, and depression. His medications include omeprazole, diclofenac, paracetamol, codeine, and sertraline. Given the likely cause of his presentation, which of his regular medications should now be stopped? So, he's having MI. Which medication should be stopped? Diclofenac should be stopped. Is sertraline safe? Wait. He's having a stable angina, is it? Episode of central chest tightness that are brought on by exertion and relieved by rest. It's not having MI. It's having a stable angina. Which ones are not good for your stable angina? I think PPI should be okay, paracetamol should be okay. Morphine should be okay for you need it for your pain, right? OA. Sertraline, is it safe? I don't know, it's between NSAID and sertraline. I'm gonna guess NSAID. Yes. Diclofenac is now contraindicated with any form of cardiovascular disease. Oh wow, okay. Reason? Diclofenac is a non-steroidal agent with marked analgesic anti-inflammatory properties, inhibitor of prostaglandin synthetase, cyclooxygenase. In vitro does not suppress proteoglycan biosynthesis. Absorption, distribution, metabolism, elimination, characteristics in patients, renal impairment, hepatic impairment. Cardiovascular. Diclofenac is contraindicated in patients with established congestive heart failure, ischemic heart disease, peripheral arterial disease, cerebrovascular disease. Patients with congestive heart failure, NYHA1, or significant risk factors for cardiovascular disease should be treated with diclofenac only after careful consideration. Since cardiovascular risks with diclofenac may increase with dose and duration of exposure, the lowest effective daily dose should be used for the shortest duration possible. Why does it have cardiovascular effects though? Patients with congestive heart failure or patients with significant risk factors, hypertension, hyperlipidemia, should only be treated with diclofenac after careful consideration. The cardiovascular risk of diclofenac may increase with dose duration. Shortest duration re-evaluated properly periodically. This pregnancy. I don't know. It blocks prostaglandins, right? Inhibitor of prostaglandin synthase. I don't know, man. It just increases cardiovascular risk. Not much explanation there. Let's just avoid it. Sertraline has no contraindications in cardiovascular disease. However, it can increase the risk of bleeding due to its effect on platelet function, so it should be used with caution in patients who are on other drugs and that may increase bleeding, for example, aspirin, ticagrelor, or clopidogrel. It's become much clearer. Diclofenac appears to be associated with significantly increased risk of cardiovascular effects compared with other NSAIDs. Advice that diclofenac is contraindicated in patients with the following: ischemic heart disease, peripheral arterial disease, cerebrovascular disease, congestive heart failure. Patients should be switched from diclofenac to other NSAIDs such as naproxen or ibuprofen. This advice does not apply to topical diclofenac. Studies have shown that naproxen and low-dose ibuprofen are the best cardiovascular risk profiles of the NSAIDs. Next question. 45-year-old man seen in emergency department with nausea, pallor, and lethargy. He has no past medical history of note. A cannula is inserted and the bloods show the following: nausea, pallor, lethargy. Very vague signs. Pallor, maybe anemia lah. Lethargy, yeah. Sodium is normal. Potassium is high, very high. Bicarbonate is very dangerous. Bicarbonate is low, having acidosis, is it? Urea is very high. Creatinine is very high as well. What are you having? Acidosis. AKI, is it? Acute kidney injury. ECG is shown below. What's the appropriate initial management? So let's look at the ECG. This atrial fibrillation, I think, looks like fibrillatory waves. I can't see the P wave anymore. You see tall tented T waves, widen QRS complex. This progresses, can become a sinusoidal waveform. Initial management: calcium gluconate, I think, to stabilize the heart conduction. This patient is hyperkalemic, so associated ECG changes, peak T waves, anterior leads, and bradycardia. Bradycardia in such patients. Worrying sign as asystole may occur. This rate is about 1, 2, 3, 4, 5, 6, 7 small boxes. Between 40 and 50 beats per minute. Very slow. Okay. Patient is hyperkalemic, so it's a PT wave, bradycardia, First priority in patients stabilized myocardium, intravenous calcium gluconate. Hypokalemia management. Untreated hypokalemia may cause life-threatening arrhythmias. Precipitating factors should be addressed. Acute renal failure, aggravating drugs stopped. For example, ACE inhibitors. Management may be characterized by the aims of the treatment. Stabilization of the cardiac membrane. Intravenous calcium gluconate does not lower serum potassium levels. Stabilization of cardiac membrane, intravenous does not lower serum potassium. Short-term shift in potassium from extracellular to intracellular fluid compartment. Combined insulin dextrose infusion. Nebulized salbutamol. Calcium resonium, orally or enema. Enemas are more effective than oral as potassium is secreted by the rectum. Looped diuretics. Dialysis. Hemofiltration, hemodialysis, aka persistent hypokalemia.
Learning medicine and so much. With hyperkalemia, hyper means over and cal refers to potassium, and emia refers to the blood. So hyperkalemia means higher than normal potassium levels in the blood, generally over 5.5 milliequivalents per liter. Now, total body potassium can essentially be split into two components, intracellular and extracellular potassium, or potassium inside and outside cells, respectively. The extracellular component includes both the intravascular space, which is the space within the blood and lymphatic vessels, and the interstitial space, the space between cells where you typically find fibrous proteins and long chains of carbohydrates, which are called glycosaminoglycans. Now, the vast majority, around 98%, of all the body's potassium is intracellular, or inside of cells. In fact, the concentration of potassium inside the cells is about 150 milliequivalents per liter, whereas outside the cell, it's only about 4.5 milliequivalents per liter. Keep in mind that these potassium ions carry a charge, so the difference in concentration also leads to a difference in charge, which establishes an overall electrochemical gradient across the cell membrane. And this is called the internal potassium balance. This balance is maintained by the sodium-potassium pump, which pumps 2 potassium ions in for every 3 sodium ions out, as well as potassium leak channels and inward rectifier channels that are scattered throughout the membrane. This concentration gradient is extremely important for setting the resting membrane potential of excitable cell membranes, which is needed for normal contraction of smooth, cardiac, and skeletal muscles. Also, though, in addition to this internal potassium balance, there's also an external potassium balance, which refers to the potassium you get externally through the diet every day. On a daily basis, the amount of potassium that typically gets taken in usually ranges between 50 milliequivalents per liter to 150 milliequivalents per liter, which is way higher than the extracellular potassium concentration of 4.5 milliequivalents per liter. So your body has to figure out a way to excrete most of what it takes in. This external balancing act is largely taken care of by the kidneys, where excess potassium is secreted into a renal tubule and excreted in the urine. Also, though, a small amount of dietary potassium is also lost via the gastrointestinal tract and the sweat. So, in order for there to be too much potassium in the blood, or hyperkalemia, there are two possibilities. The first is an external balance shift, which is most often caused by a decrease in potassium excretion in the kidneys, which raises the level of potassium in the blood. The second is an internal balance shift, where potassium moves out of cells and into the interstitium and blood. One potential cause of an internal potassium balance shift is insulin deficiency. This is because after a meal, glucose increases in the blood,